Good morning. Thank you for joining us. I'm Kate Pew Wolters. I'm co-chair of the First Steps program. We're certainly thrilled to have you with us today. Just more than a month ago, we introduced First Steps to the community. We pledged then to create a comprehensive system of support services for young children and their families to make sure that all of our children have the opportunity to reach their full potential. Today, we are very pleased to announce the first initiative of First Steps, the Children's Healthcare Access Program. The vision of First Steps is that every young child in Kent County will be ready to succeed in school and in life. To make that vision a reality, our children have to be healthy. All children deserve to have equal access to quality health care. And it's in the community's best interest that we keep our kids as healthy as possible. The Children's Healthcare Access Program has two big goals: to improve the health of children in Kent County and to reduce the cost of delivering health care. We need a broad community collaboration to achieve those goals. The Children's Healthcare Access Program involves Priority Health, local hospitals, pediatric offices, clinics, and human service agencies. I'd like to introduce the people you'll be hearing from this morning. Dr. Tom Peterson is the medical director of the project and medical director of quality at Helen DeVos Children's Hospital. Kim Horn is president and CEO of Priority Health. Tasha Thomas is the site director of the Westside Health Center, and Dr. Ron Hoffman is a pediatrician at Alger Pediatrics. The Children's Healthcare Access Program is only possible because of the willingness to collaborate and the willingness to be innovative. In addition to the partners who are directly involved in this pilot project, we also have representatives of all of the hospitals in Kent County, Grand Valley State University, the Kent County Health Department, the Grand Rapids Area Chamber of Commerce, and other organizations who are working together to oversee this initiative. We believe that we have the people at the table to really be able to impact the system. And perhaps most importantly, all of the partners of this project are committed to innovation, to doing things differently to get better results, healthier children, and a more cost-effective health system. With that, I'd like to turn it over to Dr. Tom Peterson to explain how the Children's Healthcare Access Program works. Tom?
Okay, thank you, Kate. Pardon me if I get the bugs on me. I'm going to swipe them off when I can. All right, I'm making the decision to wear the glasses. I wasn't sure if I was going to do that or not. I don't want to look old, but I got to wear the glasses. So. Okay, good morning. I want to thank everybody for coming out today to help us announce this great project that we are kicking off this month. I also want to thank everybody who's Kim and Ron and the rest of us who have come here today to help announce and give us some details and some background on the project. As a pediatrician here in Kent County for about the last almost 20 years, there's been one issue that has continuously bothered me. That's been both as a parent, as a physician taking care of children, as a resident of the county. And that is, even though that we are blessed with the latest in medical technology, we have a wonderful children's hospital, we have virtually all the children's or pediatric specialists that we need to take care of our kids, we still cannot provide all children in this county with the same quality and access to health care. In a study that we just finished and is going to be put in for publication that was supported by First Steps, we looked at all the hospital admissions of children that were under 18 years old over the years of 2001 to 2006 throughout the entire state of Michigan. So these are all hospital admissions for 5 years throughout the state of Michigan. What we found was that children with public insurance or Medicaid were admitted to the hospital almost twice as often as children with private insurance. They had almost twice the rate of mortality. The newborn babies with Medicaid or public insurance were readmitted at a higher rate within 30 days, the first 30 days of life. They had almost twice the rate of chronic diseases, the most common being asthma. For example, when we looked at asthma admissions in 2006, just in Kent County, we found that asthmatic children with Medicaid were admitted here 3 to 4 times the rate of kids with private insurance. And then also we all know by many, many resources the problem that we have continuously that the Medicaid or the publicly insured kids use our emergency room at a much, much higher rate than privately insured kids. What we also found with this study was that in the year of 2006 alone, if the admission rates for these Medicaid children or these publicly insured children was the same rate as the privately insured children, we would have potentially saved or avoided about $150 to $200 million in cost to our state. That's in 1 year, and that's just if we kept the rates of these admissions the same. So these are the key issues that we need to change. Now, working on this project, I've learned a couple things myself, or many things. We're always learning as we go along. And access to care has come to mean to me a lot more than just being accepted by a provider as a patient, which is kind of the way I was looked at it. And what we find with this population of children is that for many of these families, access means many other things. It can include resources such as transportation when it's needed or unaffordable, early and accessible mental health care, which can be a problem and has many obstacles, extended office hours for these families, especially when they can't afford to miss work, social workers for stress family situations and to hook them up and coordinate them connect them with local resources, and 24-hour access to not just phone call service, but culturally experienced clinicians to answer their questions and to provide them service. This is what a true medical home is, the continuous access to care, to high-quality care that is culturally sensitive to these populations. And that's what all our kids need, and I think that's what we should be able to provide to them all in the years of 2008. Now, talking about the issue of access, it's very difficult for children with Medicaid to find a primary care provider or a primary care doctor that many of us know. Most primary care pediatricians locally do not accept large numbers of new Medicaid patients. This is not because they don't want to, it's because they can't afford to. What Medicaid pays a doctor today in the state of Michigan to treat a patient is significantly less than the cost that they incur to take care of the patient. That leaves the hospitals and the federally funded clinics as essentially the safety net to most of these Medicaid patients. And it gives them an overwhelming number or burden of patients that they're asked to treat year in and year out. Every year in Michigan, the number of children relying on Medicaid increases, as you'll see also in our report, while the number of children with private insurance decreases. For example, in the year 2000, Kent County had about 22% Medicaid kids. Today, that number is up to 32%, or in that area, the best that we can estimate. So when you add it all up, it's getting more and more difficult for Medicaid kids or publicly insured kids to find preventative care. And this is the care that will keep them out of the hospitals, keep them at the same rates of admissions as the privately insured kids, and also if they are admitted, they're admitted in a less severe state. One good example is the one that we all see. The one disease that we saw in our study that had no difference in the hospital rate admissions was appendicitis. And that can be explained because the appendix in a child does not know what health insurance the child has. On the other hand, children who had ruptured appendix were admitted at a much higher rate if they were publicly insured. And that goes along with the fact that these kids have delayed in access and delayed in seeking care. So this pilot project, as many of us know, this is a big collaboration. I love collaborations. I think it's a great way to help take care of our needed and underserved families and kids. We have 8 provider sites that are involved that we're very, very excited about. This includes, as I mentioned, federally funded clinics, the hospital clinics, and 4 private practices. The federally funded clinics is the Cherry Street Health Service, which includes Cherry Street, Westside, who you'll hear from in a minute, and Grand Rapids Pediatrics. We also have Helen DeVos Children's Hospital General Pediatrics Clinic that is very involved, ABC Pediatrics, Alger Pediatrics, Kent Pediatrics, and Forest Hills Pediatrics. Very well-respected pediatricians in our community. This is also involves large commitments from foundations. We've had multiple foundations that have stepped up, a large health plan that you'll be hearing from in a minute, many hospitals and other nonprofits and human service agencies. So how does this project give access to our kids and give them more preventative care? Well, what I talked about earlier about the Medicaid issue and reimbursement to doctors and how it costs more for them to treat these patients than what they get reimbursed for. What we've had with this is very unique is Priority Health has stepped up to the plate and is going to reimburse participating practices more money up front to treat their Medicaid kids, to give them proper preventive care and well care. In exchange, the doctors will open their doors, take more of these new Medicaid kids in exchange for getting the higher reimbursement. This is a very unique process here that has not been done, at least to my knowledge, in many other places. This will open access to at least about 1,000 new Medicaid kids in Kent County this year alone with this project. Now, there's many more, but this is what we'll be starting with the pilot. Priority Health has long been committed to improving the health of our children and supporting preventive and primary care, especially their providers. They're very well known to helping support the primary care and provider world. This project builds on the good work that Priority has already done in our community for many, many years. The Cherry Street services and the Helen DeVos Children's Hospital clinics are already working hard to change their access issues. They're improving it by expanding hours. They're going to be improving more same-day open appointments for acute visits. Those are ill visits, and better access to well child visits, which they all have some problems with right now. Continuous access to our doctors or to your primary care doctor is what we call the hallmark to a good medical home. And everybody participating in this project is committed to improving that. Now, on one side, it helps to get kids into the physician or into the provider's office, but at the same time, we find that there's a whole other area of services that are needed to help support that process. So what CHAP is doing, or the Children's Health Care Access Program, is to provide a number of additional services to empower the parents and the families to keep them healthy. We've hired staff. We have a great staff that you guys will meet, wonderful director and very, very energetic folks. We have a nurse who's going to be making home visits to help provide health education to the families, a resource coordinator who's going to connect our families with the needed services in the community, something I never had much of when I was in private practice. I think this is a great, great thing to be able to hook up with a lot of the resources that we have, but maybe are not integrated that well with our practices at this time. There will be free same-day transportation for these kids, which doesn't exist right now, for the families who need it so they can get in and be seen that day. Intensive asthma case management, which is our biggest chronic disease problem, by our asthma management specialists that we've hired. And also our staffs are also multicultural in their expertise and also have bilingual capabilities also. So in all, what we're going to do is this project is going to include about 14,000 to 15,000 kids that will be eligible to be eligible for these services or these supports. The ages will be newborn up to about 17 years old. So that's the group of patients that will be eligible. Now, this is just a starting point. It's a one-year pilot. We hope that this can expand, or the Children's Health Care Access Program can expand to serve many, many families or many more publicly insured families throughout the Kent County in the future if we do this well. And eventually, we hope this model can expand around the state and finally provide a solution to this problem that we've wrestled with for so long. I mean, this Medicaid issue has been a problem, not just with pediatricians, but with adults and the families and our healthcare systems for years and years and years. As Kate mentioned above, our two big goals are healthier children and lowering healthcare costs. Those are the two big ones that we think we can accomplish with this pilot. The project is redirecting money to upfront care, preventative care, better management of these kids, as opposed to having to pay the consequences of them not getting it at the end, which is what we showed in our study with the higher rates of hospitalization costs. The program's based on best practices around the country, so it's not a new thing. We are modeling after what was done in the state of Colorado at Denver Children's Hospital, and also taken some of the aspects from the North Carolina project, which has been very successful. We're not reinventing the wheel, but we've adapted these programs to meet the unique needs of our community. Now, many of you know, I'll finish right here, many of you know that two of my biggest passions are prevention and collaboration. I love those two things in healthcare. And this project really, it's been very exciting for me. It's been probably the most fun project I've been involved with in my 18 years here. And it greatly exemplifies both these areas of prevention and collaboration. And it's a really, really exciting opportunity, I think, for all of us. So thank you very much, and I'll pass this on to Kim Horn.
I made a decision too, Dr. Peterson. I'm not going to wear glasses because I don't want to look old. So Priority Health is really excited to be a part of this program because it's core to what we are or who we are, is that we want to make sure that all families or all children have access to health care. And that's a significant issue here in Kent County, not only in Kent County, but really across the country. And the specific role that we're going to play in this program is to change the financial model for primary care. And it's our belief that unless we make a fundamental change in the financing structure for primary care, we're never going to create a greater access. It needs to be a systematic change relative to that. And I loved what Dr. Peterson said, is that we hope this is only a beginning, that we'll take this pilot and we'll be able to spread it throughout and get more participants into the program here in Kent County, but also that it'll be a model that we can use throughout the state for Medicaid funding in particular. Dr. Peterson talked about some of the financial difficulties of primary care and the difference between the cost and what Medicaid pays. And let me just give you a kind of a live example for that. One of the most common reasons that a child will go to see a physician is an ear infection. Medicaid today pays about $30 to treat that child, and the cost maybe is about $50 to $60 for a physician in his office or her office to care for that patient. There's a significant disparity just in that one illness. We want to close that gap so that that primary care physicians can afford to open their practices and see these children. So why would we? So if we increase the upfront reimbursement, many people say, well, what's the value to that? Well, the value to that is many of the things that Dr. Peterson talked about, that children will have more likely to have good preventative care. They'll have a medical home where the nurses and the physicians and the support staff will know them and their family, their unique issues. They're more likely to have the appendicitis not turn up to or ruptured and be admitted, or they won't be an asthmatic patient that enters the ER through an emergency room or through the hospital. That's the end game. We'll have children that are healthier, happier, families that won't be as disrupted by medical events, and will have lower cost. And if we could achieve that, we all should be very, very proud. So we're very excited to be a part of this program, and it is innovative. Most communities aren't willing to do this, and we can only do it because of all the people around the table willing to take a risk and look at it. But I think you'll see through all the people who speak today that just the passion and for our community and our kids. So thank you for coming today. And I'm going to turn it over to Tasha, who will talk about the work that she's doing.
Thank you for that. As mentioned, my name is Tasha Henderson Thomas, and I am with Cherry Street Health Services. I am representing all of the Cherry Street clinics that will be involved, Grand Rapids Pediatrics, and Cherry Street Health Services. One of the missions of Cherry Street Health Services is to provide patients with access to quality primary care so they don't have to use the emergency room. We are in the business of prevention as opposed to reactive care. Cherry Street has for many years developed programs in the areas of asthma education that are tailored to address the specific needs of populations that we serve, but the CHAP program will enable us to enhance these special services. So we're very thrilled to be involved with the CHAP project. Cherry Street currently is working to add additional hours to address the needs of patients and to provide more access to these services. We're committed to doing what is necessary to make it easier for our community's children to gain access. Cherry Street serves 44,000 individuals in the Kent County area, many of whom are below the poverty line, and they're below the poverty line by 200%. There are countless challenges to low-income families, in our community, keeping kids healthy should not be one of them. Many of the patients that we see come in with tremendous needs. Some haven't been to a provider in years because of cost, transportation, and other access issues. The support services that are part of Cherry Street Health Services and the Children's Healthcare Access Program will be a tremendous benefit to our families by creating a system that meets the needs of those families. A nurse case manager will be available to visit families in their homes and to help educate them about immunizations, well child checkups, nutrition, and other healthy behaviors, and when to call their doctor rather than go to the emergency room. A resource coordinator will also be available to connect families to housing, mental health services, and other community resources that they so desperately need. Many of the children have asthma, and an asthma case manager will be available to make home visits to educate both the children and their families about better controlling and managing their children's asthma. If a child gets sick, they can call on that day and they'll be provided with the free transportation to make it to their appointment. At the clinic, unfortunately, we don't have the financial resources to pay for home visits and some of these other support services. The CHAP program will fill in the gaps to ensure that families are getting the help they need to keep their children healthy and safe. We must change the culture to prevention and consistent health care from a family doctor rather than reactive care in an emergency room. This program will begin to change the culture of health care in our community. Thank you very much.
I'm Dr. Ron Hoffman from Alger Pediatrics. I've had the privilege of being part of this community for about, the medical community for about 25 years, maybe a little longer than that, counting residency. And it's a profound community to be a part of. And I want to thank Lou Chamberlain for not wearing a tie today, because I came up without one too, Lou. So we're, all right. Between the massive bodies of fresh water that are Lake Superior and Lake Huron is the St. Mary's River. For centuries, this river has been the conduit of commerce, bringing minerals and goods to the rest of the world. Midway down that river is a daunting drop in elevation from the Superior side to the Huron side, chock full of massive boulders and hazardous waterfalls. Ancient peoples and early Great Lakes entrepreneurs had to dismantle their goods and reassemble them downstream, resulting in a 3-month time frame to move iron ore and timber through this passage. Clearly, this obstruction prevented significant commerce from taking place until 1855, when a relatively simple engineering principle, the building of a lock system, enabled the efficient passage of goods to proceed. Today, those same lock systems on the U.S.-Canadian side ensure such passage. Between them lies a residual passage of boulders and debris, reminding the modern traveler of the 21-foot drop for which the locks were a solution. Achieving good health care is a bit akin to the St. Mary's River. At our fingertips, we have incredible tools of healing and disease prevention that have transformed human existence on this planet. The last 3 generations have seen the emergence of vaccines, anesthesia, ingenious surgical interventions and imaging techniques, antibiotics, chemotherapy, radiation, and unique pharmaceuticals. We have seen the uncoupling of the human genome, and we are knocking on the door of corrective gene therapy. We live much longer than our forebears and suffer less. Infant and childhood mortality has plummeted. My great-grandparents, who came as immigrants to Alberta, Canada, had 18 children. Only 12 made it to enjoy their adult years. And none of them saw any reasonable health care until they were ancient. Death was common, disease was inevitable. Today, those conditions would be totally unacceptable. And the key to this transformational advance has been access to the tools of health care. The tool our culture has developed is a personal relationship with a physician, one who then opens the doors to the provision of these healthcare ends. That relationship with the healthcare industry, I believe, is a bit like the locks of Sault Ste. Marie. The concept is not complex. The means are not insurmountable, but somebody needs to build it. And in this country, over the last half century, we have built magnificent institutions, including medical schools and hospitals. Just look up the hill. And we have developed employer-based health insurance to pay for it. When we look at what has transpired in that time, it's awe-inspiring. We have seen the disappearance of crippling diseases like polio and diphtheria and tetanus, childhood meningitis. We treat leukemia rather than let it consume our young. We remove an appendix in timely fashion. We build in safeguards like car seats and bike helmets to prevent the devastation of trauma. The problem is we still have a big, wide strip of boulders and a 21-foot drop of what seems to be insurmountable access for certain segments of our society. And it isn't because a lock isn't there. We have unfortunately sent the boats of our socioeconomically challenged to the waterfall rather than to the lock. I believe that the Children's Health Care Access Program opens the lock to the most precarious travelers on the shakiest boats. It provides access to the key to the system, and the system will inevitably become more efficient. There will be fewer crashes on the boulders of preventable events. But what will be necessary to make Children's Health Care Access Program a success? One, we need good physicians and other caregivers who are willing to provide the conduit. The tradition of American medicine has extended itself to the poor through depressions and wars. It can continue to do so if caregivers follow their innate convictions and open up their practices to all children. This program makes it feasible to do so. Alger Pediatrics and my fellow pediatricians are committed here. Two, education is how to steer the boat to the conduit is essential. Old habits die hard. The impulse to run to the emergency room in a reactive fashion needs to be replaced by the assurance of access in a proactive fashion. The ability to make one phone call to connect our families to support services will be a significant asset in changing this approach. Three, enforcement of the rules of the road will be necessary. Just as the freighter waits its turn to get into the lock, the user will need to make the appropriate call to get the transportation, the appointment to the medical home. There will need to be built-in guidelines that compel the users and the providers to access the system appropriately. In the meantime, this program will attempt to entice folks with the key of access to learn to use the system in appropriate, cost-effective ways. 4, access to specialty care cannot be met with the roadblocks of we don't participate with Medicaid. Fortunately, we have a fine children's hospital that shares that commitment and a good insurance company. Our goal is to sustain a system that when the storms come, our children still find the port that protects them from its onslaughts. Thank you for your attention. Here's to the hope that we all share.
Thanks, Ron, for that great analogy. You summed it up very well. Tasha, thank you for your commitment to the program. Kim, for your innovation. You're willing to take a leap. It's a leap. And certainly Tom, he is tireless, and he is excited. You didn't think that a physician could get quite so excited about something like this, but he has certainly shown us that he can. And we're certainly fortunate to have such great partners. And we've mentioned along the way that this is a pilot, and part of having a pilot means that there's an evaluation component involved in this. Our funders demand it, and our partners demand it, and we expect it. So we will certainly be looking over the years as to how we're doing, whether we're doing it right, what needs to be tweaked. We believe the program can continue to improve the health of children and the delivery of care. We know that change takes time and it won't be easy, but we feel confident that this is the right thing to do for our community. So we look forward to sharing the results of our very exciting project with you. Thank you again for coming, and have a great day.